It's a great privilege to join this and to share some of William Osler's philosophy with you all. So this talk is entitled William Osler's Medical Philosophy, looking at his philosophy to the guiding principles of minimally invasive and non-invasive surgery. So this is Oxford, where I work, called the City of Dreaming Spires. It's quite cold at the moment, but we haven't got the snow just yet in Oxford. So William Osler, one of the things that he said and implied was diseases that harm require treatments that harm less, which is why we're very interested in talking also about HIFU. But Mencius, as you may know, said, compassion for fellow humans is a matter of the heart, and righteousness is the path. So a little bit about William Osler to start with. He was born in Canada, in Ontario, in 1849. He was the son of a priest, and he was top of his year at school. His favorite book was one called Religio Medici by Sir Thomas Browne, on science and medicine and religion, which lay on his coffin after his death. But he was also an expert in what he called the greatest of books, the Bible. And initially, in fact, he wanted to become a priest, but he changed his mind to medicine and qualified in Toronto in 1872. And after doing some postgraduate training in Europe, he returned to McGill University in Canada in the Faculty of Medicine as a professor in 1874. And here is the old pathological museum in McGill with many of Osler's specimens. Osler did an awful lot of dissection and post-mortems and tended to do post-mortems on a lot of his patients and on many other doctors' patients in his early days. He went from Canada to America, initially to Pennsylvania, but then to Baltimore, where he was one of the founding fathers of Johns Hopkins University. And that picture in the bottom hand shows the four founding fathers: Welsh, who was a pathologist; Halstead, a surgeon, who actually was the person who introduced surgical gloves into the operations. And then Osler, and Kelly was a gynecologist. He married in 1872 the widow of Samuel Gross, who was chairman of surgery in Philadelphia. And in fact, he had two sons, but sadly the first one died after only a week, and his second one, Revere, after great-grandfather of his wife, was killed very sadly in the Second World War, which absolutely devastated him and his wife. His greatest accolade is that he taught students at the bedside. He took them to see the patients and to talk to the patients by inspection, just looking, by feeling, by listening, and then thinking about the diagnosis. And he has many famous quotes. Here is one: medicine is learned by the bedside and not in the classroom. Here is a postage stamp of Osler, a Canadian postage stamp. But one of the great things he said was the good physician treats the disease, but the great physician treats the patient who has the disease and thinks more about the whole patient rather than just the disease itself. And here he is at the Johns Hopkins writing his Principles and Practice of Medicine, which was the first time that a scientific and clinical book was produced. And this book, The Principles and Practice of Medicine, was in publication down many different versions for probably about 50 years. And here is the first Chinese edition in 1910, translated in Shanghai. We have a copy of that in Oxford. I've never seen another copy. If anybody comes across a copy, do keep it. And if you have any spare copies, I'd love to have one myself. So he said that it's simpler to buy books than to read them, and it's easier to read them than to absorb their contents, which I'm sure many of us will appreciate, especially as we're coming up to exams. He also said that if you study medicine without books, it's like sailing on a sea with no charts. But if you study medicine without patience, it's like not going to sea at all. He came to Oxford in 1905 as the Regius Professor of Medicine, and he died in this house, 13 Norham Gardens, which is about 2 miles away from where I'm living at the moment, in 1919, so 100 years ago last year. And here is Osler in 13 Norham Gardens, and that room is essentially unchanged. Today it's preserved now as a museum, as his library. And here we are visiting with 2 of your senior professors, which was a great joy to welcome them to Oxford in a couple of years ago in front of William Osler. So his philosophy was compassion, care, but he was a good scientist. He was not arrogant. He thought about the whole patient and not just about their clinical situation, but the physical, the emotional, and the spiritual side of things. And he was very compassionate. And as a compassionate surgeon, he was experienced, like I'm sure many of us do, the anguish of patients that he was unable to cure. And people said of him that if you want to see the chief at his bedside, then go and pass, go and find some old lady or old gentleman with a chronic and hopeless illness, and they always get their best from Osler. He said it was important to care more for the individual patient than the features of the disease. And he said, put yourself in their place. The kindly word, the cheerful greeting, and the sympathetic look. These are what the patient understands. And just to show his compassion, when he was a young doctor in Canada, he treated a boy who died of smallpox. And when he was very senior, when he was the Regius Professor of in Oxford, many, many years later, he met the boy's sister and found out that their mother was still alive. And the sister said, oh, Osler, that's an interesting name. My brother was treated by a young doctor in Canada called Osler. And William Osler said, yes, that was me. I remember him. And he sent to Canada for a picture of the boy's grave. And when he was traveling down to Devon, he took it and called in to the mother and gave the mother a picture of her son's grave. So that's how compassionate he was. He was not arrogant, and in America, he was the doctor to many famous people. And that was one of the reasons people were after him all the time. And that was one of the reasons why he came to Oxford. His wife was delighted to bring him to Oxford to get him away from all the people that were wanting his attention. Respect your colleagues, he said. Don't try and treat yourself. If you treat yourself, you've got a fool for a patient. His vision extended far beyond medicine. He said, start a bedside library and spend the last half hour of the day in communion with the saints of humanity, all the people who have written good books and done great things, not just in medicine. And he said that the young doctor should look at early for a pastime that will take him away from patients and pills and potions. Get away from medicine. It's important sometimes to relax and to get away so that we don't get burnout. He said he was great with children, and he said we're here to add what we can to life, not to get what we can. And he said it's one of the duties of the physician to educate the masses not to take medicine. And this is a very interesting thing, which I can associate with to some extent. He says the young physician starts his life with 20 drugs for every disease, and the old physician ends his life with 1 drug for 20 diseases, which is very interesting. This is, I think, particularly true at the moment during COVID. Soap and water and common sense are the best disinfectants. That stood the test of time over 100 years since he first said it. And the practice of medicine's an art, not a trade, a calling, not a business, in which your heart will be exercised equally with your head. And he was prepared to say he didn't know when somebody asked him a question and he didn't know what the answer was. And he was didn't want to take all the credit for himself. He said, let every student have full recognition for his work and never hide the work of other people under your own name. Should your assistant make an important observation, let him publish it. Through your students and your disciples will become your greatest honor. And I'm sure we've all known people who are like that, and perhaps people who are not like that, who take the credit for themselves rather than giving the credit to the people to whom the credit is due. So his greatest legacy, his greatest contribution was to insist that students learn from seeing and talking to the patients at the bedside. And here's one of the very famous Chinese leaders who said the tracks of a commander, but I would also add a doctor, are courage, wisdom, humanity, and integrity. And I think probably throughout the world, certainly in Europe, surgeons learned their skills in war. Ambrose Paré was one of the greatest surgeons in the 1500s, surgeon to 4 kings of France in succession. And he performed amputations with ligatures. He learned that actually if you, rather than putting boiling tar on the wounds, which is what they used to do, if you actually dress it with something much softer, and he was only doing that because on one occasion he ran out of boiling tar and had to use some rose oil and something much less serious. And he found actually that those patients did much better. So in a sense, that was the first clinical trial recorded. But he then, after that, decided not to use boiling tar for cauterizing the wounds, but something much softer and ligating the wounds. Here's a gentle Mandarin doctor in the 19th century. And of course, we're very fortunate. I appreciate that in China, acupuncture has been around for a long time. In Europe and the West, the first anesthetic was done in 1946 when I think they extracted a tooth in America under laughing gas. So what about the trip towards non-invasive medicine? As Osler said, diseases that harm require medicines that harm less. And he also said this, that the philosophies of one age have become the absurdities of yesterday, and the foolishness of yesterday has become the wisdom of tomorrow. And here's one example of that, in 1910 in the UK, the chief of the general staff looked at the aeroplane and said it was a useless and expensive fad. Well, how wrong he was proved over the years. So when I was in full-time NHS practice, my major surgery was in kidneys and kidney cancer and renal transplantation. And the top left is one of our operations where the tumour from the kidney was going up towards the heart, doing that with the cardiac surgeons. So we go to laparoscopic surgery, to robotic surgery, and then to non-invasive surgery. So I tell my colleagues that I've missed out the middle two. So I've gone from the big open surgery to non-invasive surgery, and I've actually missed out on the laparoscopic and robotic surgery. So here's Osler again. First, do no harm. And so a little bit in the next section, just about our high intensity focused ultrasound work in Oxford, with a fantastic collaboration over the last 20 years with Chongqing and the HIFU group, which has been absolutely fantastic. So on the left-hand side here is the HIFU unit that we had purposely built back in 2002. Now we're in the big cancer center down below, and we've had the JC200 machine. And I'm sure I don't need to tell most of the people who are watching this about HIFU, but ordinary ultrasound, of course, one's interested in the image, the scatter. But even with ordinary ultrasound, you get very slight, you get absorption at the focal point and a very slight temperature rise. But if you put the temperature up 10,000 times, then you can kill cells. And it's a bit like, of course, the analogy of if you have a magnifying glass and you focus the sun's rays on a piece of paper, then you can set fire to it. And of course, you can do the same with ultrasound, not setting fire to things, and it doesn't go through air so well, but it goes through water and through the body. And so here we are just targeting a liver tumor, just painting it out really, firing it and then moving it along a little bit, and finding this just area of coagulative necrosis at the focus, just a cigar-shaped lesion, a couple of millimeters in diameter and about 1 centimeter long. And that's what it looks like in a piece of ox liver. And this is a slide from Gail Tahar, one of our, Gail's called, certainly in the West, the queen of HIFU. She's been working on HIFU for some 40 years. And this, we've been working with her very closely. But this is a slide just showing the difference between live and dead tissue, a very fine margin. Now, it was James Kennedy, actually, who wrote this article for Nature Reviews, who actually started all the work in Oxford with me. And it's really to him that we owe a huge debt of gratitude. He did his PhD with me. He set up the first unit. He ran the first clinical trials. He's now actually changed direction. He trained in Cambridge and then did his PhD in Oxford. So he's an incredibly bright chap. But then he went to Wycliffe Hall, Oxford, and trained as a priest. And now he's a priest just a few miles north of us. And actually we saw him recently and just had supper with him recently. But he still keeps up with what's happening in HIFU. And we're so grateful for all the work that he did in the early days. So we've looked at a number of different things over the years in Oxford, mainly in clinical trials, although we're treating the fibroids now without clinical trials. But here's James and one of the colleagues, Roland Illing, who's now working in the United States, writing in the British Journal of Cancer in 2005, our experience with liver and kidney tumours, for which we got CE approval of the JC machine, and it's now widely accepted. And we had the first one courtesy of HIFU and Chongqing in the Western world, but now there are some 30 or 40 around Europe. And this was a wonderful piece of work that was done in China, 20-center study. My colleague Peter McCulloch had helped a little bit in getting the publication ready, going through the ideal collaboration. And this was published in the British Journal of Obstetrics and Gynecology a couple of years ago, and really has made a huge difference to the ability to treat fibroids, I think, in the West and in this country. That's probably familiar to most people, showing the effect of HIFU on a fibroid. And in the Chinese study, 20 participating centers with 2,411 women, and 1,350 just over had HIFU, 470 a hysterectomy, and 586 a myomectomy. And very, very few events, side effects as opposed to the surgery. And hospital stay, I appreciate that in China, I think often the patients have to stay a few days because of the distance they travel. We normally keep patients in one night, although most of them are able to go home the same day. So largely, I think, as a result of that work that was done in China and published in the British Journal of Obstetrics and Gynecology, we had NICE approval for uterine fibroids in the UK, for ultrasound guided in the UK in July 2019, which was a fantastic achievement, and allows us to go on treating the fibroids. We've done some kidney work. It's difficult to treat the kidneys because of the problems with the ribs and the perinephric fat. But in renal transplants, where you've taken the fat away and you've transplanted them into the groin, actually, it's much easier to treat. And here was a patient who had a tumour in a renal transplant that we treated with HIFU. We did actually then remove the tumour afterwards, and found that 90% had been destroyed. There was a little rim of tumour around the edge, but 90% had been destroyed. We've looked at some patients with sacral chordomas, which is theoretically benign, but it's often very locally invasive. And this was a patient who had trouble sitting down because of these chordomas. And you can see the top left is where the tumour was, and here's treating one side with good result, here's treating the other side with good result, and here's 2 weeks after the third HIFU treatment. And this patient, who was having difficulty in sitting down, was remarkably improved following that. And we wrote up some cases in the Neurosurgery journal. Now, the other interesting thing that we've been doing in Oxford recently, my colleague Konstantin Kousios and Paul Lyon have been looking at targeted drug delivery. So what they do is they basically take some doxorubicin and put it into thermosensitive liposomes. These liposomes are a little bit like butter. So what happens is that they are stable at 37 degrees centigrade, but at 42 degrees centigrade, they break open and release the drug. So what you can do is you can put some drug into the middle of these, and then you put a non-focused HIFU ultrasound beam over the tumour. And then what happens is that as you inject these peripherally, I think we have a picture of this. So you inject the drug peripherally, you take a biopsy of the tumour first and also monitor the temperature in the tumour. Then you put thermodox peripherally, and then you put an ultrasound beam over the tumour to heat it up. And then as the drug goes through, it breaks open, and you get this effect, local effect on the tumour. So here you can see a tumour, and here you can see a tumour that's been killed following the injection of doxorubicin. So this was a first-in-man study, and it was written up in the Lancet Oncology in 2018, the first time that this had been done. And we're also looking now at targeted drug delivery in the pancreas. We're looking at the possibility of getting drugs into the brain by breaking down the blood-brain barrier with HIFU. And we're looking at other possibilities. We're treating pancreas also with HIFU without the targeted drug delivery. So we've got several other trials going on. So this slide is a colleague of mine, Peter Radcliffe, who we were delighted won the joint prize, Nobel Prize in 2019. We've done some work together, and he has been working for many years on how cells sense and respond to oxygen depletion. And of course, the long-term aim will be prevention rather than cure. But as long as diseases are there and cure is needed, then I think HIFU is going to be a leading way forward. And I think one of the things that COVID has done, for all the problems that COVID has caused, it may well just improve the take-up of HIFU, because of course HIFU is non-invasive. Some of the treatments can be done, for example, fibroids under sedation. You don't need an operating theatre to do it. So I think that in these days, when one's worried about, certainly in this country, we have so much pressure on the operating theatres, and even more so because of all the things that have been cancelled, then I think that HIFU is going to be one of the leading ways forward. We've had a fantastic team in Oxford. We're so grateful for the wonderful collaboration we've had with Chongqing and Zibiao Wang and Rosie and all the other people who've worked there, people who've come over to service the machine and set it up. A lot of work with Professor Gail Tahar, and of course we have a huge team in Oxford that have been involved, and Konstantin Kousios, who's in charge of biomedical engineering in Oxford now. We have a very, very close collaboration with him, and he's doing a lot of the preclinical work, and in fact he was leading on the targeted drug delivery. So that's just a little brief outline about William Osler, about non-invasive medicine. And so thank you very much indeed. I'm sorry I can't be with you in person.